Okay, Mr. Chairman, we're ready to go.
All right, thank you. And good morning, everyone, and welcome to the Eastern Idaho Public Health Board meeting for Thursday, April 29th. This meeting is, of course, being held mostly virtually. Public is able to view it on our YouTube channel, as well as a room that is set up at the Eastern Idaho Public Health Building where there is staff present. I do appreciate each one of you for being here today. I do need to excuse Commissioner Mendenhall. He emailed me this morning and had an issue come up that he needed to attend to, so will not be joining us. We will go ahead and begin with our roll call. And we'll begin with Custer County. Commissioner Butts.
Commissioner Butts, present.
And Clark County.
Commissioner Shenton, present.
Fremont County.
Commissioner Dance, present.
Commissioner Mendenhall is absent from Madison County. Jefferson County.
Commissioner Young, present.
And Teton County.
Bill Lake, present.
Our physician, Dr. Nelson.
Barbara Nelson, present.
And I'm Brian Reed from Bonneville County. I do not see Commissioner Madsen from Lemhi County yet, unless I missed her. So we will hope that she joins us as well, but we do have a quorum. Appreciate each one of you being here. Of course, we're also joined by our director, Jerry Radkow, and our epidemiologist, James Corbett, our clinical services directors, many of them in the room and in the meeting with us, and we will hear from many of them later, and other division directors. We will also have reports. A good share of our meeting will be reports from our fiscal officer, Stephen Thomas. So again, we appreciate each one of you being with us today. We'll go ahead and go to our COVID-19 situational report. And Director Radkow, I will let you kind of lead the discussion on that, if you will. And
Okay.
Commissioner Madsen, I see you just joined us, so welcome. Thank you.
Yes.
All right. Thank you. And I want to just welcome Dr. Gonzalez from Madison Memorial Hospital with us this morning. The hospitals have agreed to send one representative at this time to report on behalf of all the hospitals. And so I'll turn it over to her for her report.
All right. Well, good morning, everybody. Can you hear me all right?
Good morning, Dr. Gonzalez. Yes.
All right. Nice to see you guys. So, Jerry, I should have talked to you a little bit before we did this, but I'm going to just ask you to chime in on a couple things that I know that you'll know off the top of your head, so I'm not worried about it. But what I would say for our region and what we're seeing for the hospitals and inpatient and outpatient, I'm not getting a feel that what we're feeling now and seeing is much different in the state, and even got information from our major medical center at the University of Utah, because a lot of us in southeastern Idaho, depending on situations, need to refer to the University of Utah or certainly IHC. So what we're seeing in the hospitals, we really are not seeing a surging of COVID patients needing the inpatient services. Every hospital will see and need to treat this disease, and we're starting to move into a process, continuing to move into a process of how do we do this well in healthcare and hospital settings in the long term? And I'll try to loop back to that, because I would say that us included, and I imagine this board and others probably had some type of hope that we would stamp this out and we wouldn't see it quite as long term. You know, you always have hope, right? But the interim measures that we had in place, like screening, if you visited any of the hospitals, screeners, our COVID wards, some of these things that we've had, we're just realizing we need to move these processes longer term. And so each facility is working through that, what it means to them. Certainly, if you think about Eastern Idaho Regional Medical Center, we need to refer to them. Idaho Falls Community Hospital, Salmon, Driggs, a lot of the hospitals need to refer to both of these. And so they're doing the exact same thing. You've got, the inpatient census that you'll see. And I would say that for, the University of Utah, for example, they're currently only at 16, I shouldn't say only, but they are at 16 inpatient COVID for primary COVID reasons. One of the things that I know I had received from Casey and from David is that the patients that they're seeing some of these are certainly longer term, and they've been there up to a month. And finding ways to transfer these patients that need to be transferred to what's called an LTAC, or a long-term acute care facility, is a challenging process. And the hospitals in Idaho Falls have figured out how to do this and work well with the EMS, and how do they get the high flow oxygen and the needs that they need to transfer these patients. My point on that is whether it's from the community transmission of this disease all the way to the point of caring for these patients that might need to be vented for a very long time. And now the long-term acute care facilities, which are very specialized, these are not nursing homes or rehab facilities in a sense. They these patients are still vented. And there's one in Boise, and then there's certainly one in Murray. And my point is there's still effects across the system of healthcare, and we're trying to work through that. But the good news is, all hospitals are busy. It's just not busy necessarily with primarily COVID. And, ERMAC continues to be busy with their burns and other things. And, all of us at Madison, babies and things like that. The staffing that we've continued to report on to you guys, again, staffing does not seem to be an issue for our hospitals related to surging of COVID patients. There's probably some after effects that we'll all see in staffing for probably a while due to a pandemic. And I don't think that'll be just healthcare, but we certainly have some of those different filling or issues throughout our facilities. And then lastly, we're all seeing a waning demand on immunizations. And I think that's mixed feelings. One, I believe that we had hoped we could, have such a demand now that, it would help us with stamping out this disease and then give some hope from the inpatient side. But we do have, we partnered with BYU Idaho yesterday and gave a couple hundred shots there, and a lot of interested questions and things, and other hospitals and partners are doing the same thing and educating and doing the best we can. So I tried really hard today, Mr. Chairman, to kind of cover it from a broad perspective, but I've got, the guys did a great job. And everybody gave me some good details on what's going on in their hospitals, but that's really the trending of what we're all seeing. So I'd entertain any questions. And Jerry, where I was going to kind of punt it your way is just if you had seen or heard anything different than I had from trending from the state standpoint of staffing or any particular surges that I haven't noticed, just to make sure, because I know you get some really good uptime data.
No, thank you, Dr. Gonzalez. We have not heard anything different from across the state. So very similar reports from what we hear.
Other questions for Dr. Gonzalez? And I appreciate that overview, Dr. Gonzalez. I had one that perhaps you and Dr. Nelson could help me with. It appears if you go back to, when was it, in January, February, when our case counts went very low, district-wide, our hospitalizations got as low as about 18. And I went back and followed it through, and we're about at that same level and time frame, and yet we're showing 35, nearly double of what we were at that time with the same caseloads. Is there a reason why it appears there's a greater percentage of hospitalizations now compared to the last time we had that dip?
Chairman Reed, I think there's a couple issues. There's better treatment, so people are surviving more. A lot of times the drops in inpatients that we saw were due to deaths, but also these patients are really in for the long haul. Many of them are in for several weeks.
Okay, that helps. And yeah, that makes sense to me, especially with the better treatments. So it is becoming more survivable, yet it's taking that hospitalized treatment. Anything else?
I would just add to that she exactly what she said. I can ask when we report next month, maybe we look at what percentage of some of these inpatients that we have been in the hospital a little longer, and we can kind of look at that percentage of the long-term patients that are in hospitals versus those that have only been there for a matter of days. We can come up with some type of metric there if that would be helpful for the board.
Yeah, that would. That is interesting. Yeah,
Okay,
I appreciate
I'll do that.
Okay. Are there any other questions for either Dr. Nelson or Dr. Gonzalez at this point? So go ahead, Director, we'll continue. Thank you, Dr. Gonzalez.
I don't know if you, sorry about that. Thank you, Dr. Gonzalez. A moment ago, I had on our screen just the overview, and yesterday, both Madison and Jefferson counties fell below the metric of 15 per 10,000 population, an active rate of 15 per 10,000 population for 14 consecutive days. And so they've been moved into the green or the minimal risk level. And assuming that Bonneville stays there today, they will also move to the green. And so that will mean all of the counties in our health district will be back into the lowest risk level that we've identified in our plan. So I'm going to turn the time over to James Corbett to hit some of the highlights, and then we'll go to Amy on immunizations.
No, Jerry did a great job of explaining where we're at overall. The current cases for our district are at 201. If we can go to maybe the percent positivity page. And again, the percent positivity, I'll say we do get a week late. So this number over here on the very right will indicate 8.09. I just received some just this morning, so we haven't had a chance. It'll go up later today, but it's at 6.5%. So still continuing to decrease on the percent positivity. That number, you can see we flirted with it in January just a little bit, but we have not seen lower than an 8 since June of last year, before our rise in cases around the 4th of July. So we're excited about the continued downward trend, and hopefully that will continue. So hospitalizations, as you pointed out, Chairman Reed, have stayed and plateaued at a little higher level than we'd like to. So you can see here on that upper graph there, in January, we did get lower than we are currently. I would attribute that as well, from what Dr. Nelson said, to some long-term patients that we're having in our district. It is concerning and we're aware of it. But we hope that that decrease continues. We do know, I'll just use this time, we do know that we have had a recent peak in deaths as well over the last 10 days, where we've seen a number of individuals. That's always a disappointing number that we hear and report. We do know that peak cases happen and then hospitalizations happen, a few weeks after those peak cases, and then deaths occur a few weeks after that. So that's not a trend that has suddenly stopped. It still is continuing, but we're hopeful to see these hospitalizations continue to decrease like our cases have. Age demographics are skewing slightly younger of the individuals that are contracting the disease. We certainly have the time, why we believe that that's probably due a great deal to vaccines getting into the older populations and their higher uptake. Amy will probably talk about that in a few moments, but we do think that that age skewing younger is due to those older populations having a higher uptake of vaccine. The variants, while we don't display them here, they're at the state of Idaho's website, coronavirus.idaho.gov. We do get quite a few questions regarding variants. There's been 2 identified in eastern Idaho. The UK variant is by far the predominant one. And then we've had a handful of cases of the California variant. We've had a total of 44 cases with the variants identified in our area over the last 6 weeks, which would put it about 1.5% of our total cases that we've had during that time. So not a great deal. Do I think that that's probably the only variants? No. Certainly we know that we only see, there isn't sequencing done for every positive individual that's had a test. Only those that providers do send in, as well as those that may indicate through their initial testing, through a process identified at the lab, that it may be a variant of concern. So again, our predominant one, just like this graph shows, really is the UK variant, the B117. And then we have had a few, a handful of California variants in our health district as well. But neither of these South Africa or New York variants have been identified in eastern Idaho. With that, I'll stand for any questions.
Questions from the board?
This is Commissioner Young, Mr. Chairman. I have a question.
Go ahead.
Yeah, James, I'm just wondering, are there any variants that we need to be concerned about? I've heard of different ones, but do you think there's an issue with any one of them?
Yeah, and certainly Dr. Nelson can chime in on this, but the California variant is of concern because it has it's been a little bit resistant to some of the treatments. You can't use just the antibody treatment that they've come up with before that monoclonal antibody, so they have to attack it in a little bit of different way. All these have some increase that we showed there on the screen. There's other variants that go on all the time, but these are the variants of concern that we call them. So these variants of concern normally have either a increased transmissibility, it's easier to pass along to others, or potentially a slightly different treatment course that may not be as effective. So both of those would be concerning to us, and hence we have them titled variants of concern on the state website, and those are the ones that we actually display. We certainly don't want a resurgence from the variants, but we're very optimistic right now that the vaccine helps to cover those variants. So again, the best course of action. It's probably still the vaccine, as well as all those other measures that we've promoted throughout this time.
Okay, thank you. Any other questions? Okay, we'll go ahead and move to our Division Director, Amy Gammett. You've been busy.
Thanks, Commissioner. This is just a glance. As the nation hit 1 billion doses of vaccine administered this week, the state of Idaho hit a milestone with over 1 million doses administered here. This is just a little bit of a look at the vaccine landing page. A couple things to point out that James also alluded a little bit. The 16 plus population for Idaho that are complete for vaccination is 33% compared to 65 plus. I'm sorry, that's just for one dose. So let's compare the one doses. I'll jump back here a little bit. 16 plus 42% compared to the seniors, 65 plus at 72.4%. They're broke down a little bit different on the bottom. Also on this first page here to know on the very right side, if we'll look, all along, early on, as demand was high, supply was low, and we tended to have just a little bit of vaccine left over each week. As demand has decreased, of course, as supply has increased, we've seen that accumulate now over the last several weeks. And so statewide, we're now sitting at almost 4 weeks of vaccine on hand. And you can see that in the very far right graph there. Just for Eastern Idaho, we've now administered 122,000 doses. Here at the health department, we've actually administered almost 50,000, so about 40% of those doses. That's a lot of vaccine given in the state of Idaho. When you look at the map there in the top left of the vaccine we received, we actually are the highest, only by a percentage point compared to some of the other districts of our vaccine, though, that's been administered or at least reported administered in IRIS. So that says, all of our providers here are getting vaccine and getting that, doing a nice job getting that into people's arms. So vaccine uptake, when you look at that on the map at the bottom left there, that does show uptake per health district. And those vary. Ada County is the highest in District 4. A lot of that has to do with Blaine County is extremely high in that percentage. This time I tried to break up because it's hard to see when we go to it, I tried to blow up on the very right there, our individual uptakes for our counties. So Bonneville County, and it might be a little bit blurry, Bonneville and Teton County at 45%, and then down to Clark and Madison County at 34%. Just to put in perspective a little bit for Madison County, remember there are one county that has the highest population of that younger population. And so they've only become eligible, recently. And so it's not surprising that that would play into that a little bit. Madison County being a little bit lower percentage, hopefully as more of that younger population, hopefully uptake of that age group increases, and we'll see that percentage come up in Madison County. And we now actually have a tool. I don't have that. The directors all have access to a tool now that within a county, we're also able to look at the zip codes in those county. For example, in Bonneville County, we're able to look at 83401, 83402, and we're going to have some focus to look specifically if a zip code also needs additional access to vaccine. And so again, as these tools become available, demographics of who's been vaccinated, who hasn't been vaccinated, that'll help us maybe put some focus on how to get vaccine to those unvaccinated groups. Just in light of the increased vaccine that I talked about, Idaho has put out a vaccine wasted guidelines. We know, again, as supply is up, the focus has to move towards getting vaccine in arms. So early on, where we might have limited a specific county if they didn't have 6 individuals to be vaccinated, now that focus is more as getting that vaccine in arms. And so we might go up there in Clark County, for example, if 2 people are scheduled, go up there and administer that vaccine to those 2 people, knowing that to do so, that we'll have to waste some vaccine. And so the state of Idaho is expecting that. They're not holding that against providers, so they won't be penalized. But clinics still need to have, a plan in place. And so we still do. At the end of our day, we still have people that are willing to come in, right at the spur of the moment for a vaccine. Here in Bonneville County, we're still in the mall. So at the end of the day, we're putting a sign out saying, vaccine available right now. And we've still done a very nice job of not having to waste vaccine at the end of the day. But we know that that shift is moving and that we are going to see some vaccine wastage just to get vaccine in everybody's arms. The state of Idaho also has shifted their focus on their registration tool. And so before, you could sign up and then have a provider reach out to you to receive a vaccine. They're more moving towards you being able to find a vaccine, hopefully the same day you're wanting to look. And so even though the registration tool's there, where a provider can pull from that to call you for a vaccine. In fact, I pulled it this morning, and where we had thousands on there, before, there was 4 individuals on that list this morning. And so that tool definitely is becoming less useful. More so now they're wanting you to go in and find out where you can find a vaccine. And so they've added some of these other things. There's walk-in clinics. Our clinic also allows walk-ins to come in that day, or where you can get right to somebody and schedule that very same day. Again, instead of waiting for somebody to reach out to you. I just wanted to touch on the breakthrough cases. I figured that we would have some questions on that. I've said it before. I think I said it last time. Vaccine's 100% effective, but it's still a very great vaccine. Vaccine breakthrough cases are a very small percentage. In fact, the CDC's even developed now a national database that they'll share some of that data at the May ACEP meeting. There's the evidence coming in, though, is great, showing that vaccination may make illness less severe. And then I think James touched on a little bit that we know that the COVID vaccine also is doing a great job to protect against most of the variants out there. This is just the national look at the breakthrough cases. I know in ours there was some debate on females versus males. So I was trying to look at a bigger cohort of vaccination breakthrough cases. So nationally, even though it shows 64% of breakthrough cases are from females, a lot of that also, when I was looking at the data, more of them have been vaccinated as well. When you think of the early vaccination, healthcare workers, a lot of nurses more so lean towards being female. And so higher numbers of females vaccinated. So it's not surprising a little bit to see a higher number of the breakthrough cases in that females. And then hospitalization and deaths very low. Some of those hospitalizations down at the bottom, you'll see 1/3 of them were reported asymptomatic or in the hospital from non-COVID related. So again, very few breakthrough cases in perspective of the amount of people vaccinated and then the number of COVID cases we're seeing. So again, vaccines doing a great job. These are just more specific to Idaho's breakthrough cases. It's actually a little bit more than 193 now, just some of the demographics. They've been identified in all age groups. 40% still report no symptoms. Of the 60%, though, that are reporting symptoms, 90% continue to be mild or moderate. 2 individuals that are fully vaccinated have been hospitalized, and there has been 1 death reported in the state of Idaho on a breakthrough case. And James, I wasn't sure if he would have that slide in there or not, so that's just the variant breakdown. A couple of updates from manufacturers. Pfizer has submitted all their data to the FDA, and they're asking for clearance to expand to adolescents ages 12 to 15. We're really hoping to see that at the May ACEP meeting, where we'll be able to vaccinate down to 12-year-olds. Right now, currently, Pfizer is the only vaccine for 16 and 17-year-olds. Moderna is also looking at clinical trials in this age group and even younger. And I suspect that we'll see them submit their data for the same request. A Janssen update, or Johnson & Johnson. I'm sure everybody, seeing the news of the pause on the Johnson & Johnson vaccine. It was So basically the vaccine adverse event reporting system did show some blood clots in place, also in conjunction with low platelets. And so this did trigger a pause in the vaccine. ACIP did meet last week and they unpaused that. The cases were mostly in women younger than 50 years of age. They did determine that the potential benefits outweigh the risk. So in clinics, the recommendation has been to at least to let women know in that age group that there are vaccines available, that this has not been reported, but the Johnson & Johnson vaccine is still very rare side effect and a good vaccine. CDC and FDA will continue, as always, to monitor the vaccine. And then I just wanted to point out the reason that trigger was identified is all the safety things that are in place. So those safety things, the VAERS reporting is looking for things that weren't seen in the clinical trials. And so they're doing exactly what they should be doing, looking for that and allowing them then to evaluate that data, and move forward. So where's our focus today? So as we move towards herd immunity, the thing now is just ensuring that people have access to vaccine. And so trying to bring vaccine to people, look at areas of populations that are unvaccinated, and just ensure that they have it accessible, timely. And then the other thing is we just want to make sure that we have up-to-date and accurate vaccine information available out to the public. And that's it. I'll stand for questions.
Any questions, board members? Commissioner Young, did I see you had a question? Or?
No, but I did not have one.
Okay, I apologize.
No problem.
Yeah, indicate you might. Any questions from board members?
Mr. Chairman, I'd just like to add that, as Amy mentioned, the focus is on now getting the vaccine to people that may not have been eager to get it at the start. And the state announced that just this week that there's going to be $9 million in funding available for providers that they can apply for that funding to assist them in doing more mobile clinics or, unique clinics, not the standard situation where the patient comes into the provider's office or, in our case, to our mass vaccination clinics. And so that information will be available. It should be available today on the Department of Health and Welfare's website, and providers will be notified of that. As we look at, the decrease in demand in our large clinics, we're also looking at shifting focus to do more on-site clinics for businesses, and we'll be promoting that. Information should be going out in the next couple of days that if a business would like us to come on site to vaccinate their employees, we're happy to do that. And I would just put a ask out to each of you that if you know of needs within your counties, we've had the same conversation with the emergency managers. If you know of needs within your counties where vaccine needs are not being met, we would really appreciate you passing that on to us so we can work to address that.
Okay, thank you. The effort that you've all been making has just been extraordinary, and it shows in the amount of vaccine that have been given in our district. So we're doing very well, and appreciate all the work that you have all done, Jerry and Amy and James and all of you there. Any other questions before we move on? Okay, we'll go ahead and move to item 3 then in our agenda, which is approval of the consent agenda. We can do this in one motion, but I'd like to review a couple of items. So if there's any changes that are needed to the minutes, and then also I hope that everybody's had a moment to review the fiscal year 21 year-to-date financial report, as well as the sub-grant ratification. Any questions, or Director Rakow, any explanations you would like to give?
Not necessarily, Mr. Chairman. Likely when we get into later, when we get into later agenda items, we will probably refer back to this page to point out a couple of things there, but unless there are any specific questions.
Any questions from the board? I had just a couple that I didn't understand. I probably should, but the Millennium Fund balance, has been declining monthly. Will that continue? It will, correct?
Yes, it will. So we get money appropriated to us from the legislature through the Millennium Fund Committee, and we get that in 2 payments. One payment in July, and so then each month as we do that work, that account balance decreases.
Right. And then the other question I had was just the COVID donations of 217,000 plus. Where are the donations coming from?
Early on in the pandemic, Floor, Idaho, and DOE had reached out to us. They had opportunity for us to receive some money. It was some settlement funds that they had received, and they passed that on to us to assist with the COVID response. And so that's what that represents.
Okay. Any other questions from the board before we move on with the motion? On the subgrant summary, Jerry, I guess so is that from the Idaho Department of Health and Welfare that they reduced the funding?
Yes, that is correct. And sometimes this happens as we get to the end of the fiscal year and we know that we're not going to be able to spend out all the funding that was allocated to us through the subgrant, that they do a subgrant amendment and that money reverts back to them, and then they can spread it out to other areas in the state potentially that may need some additional funding. The oral health ones in particular, and we'll talk about that as we get into the budget. But we lost our dental hygienist a few months back, and at this point do not have plans to replace that position. And so there's no way that we can accomplish the remainder of that work in that subgrant. And so those amounts are being reverted. And then with the tobacco education and prevention, same thing. A lot of that is doing work in schools and other things, and where it's just not been possible this last year with the COVID restrictions, we're not able to spend out all that funding. And so it's going back to the state.
Okay, thank you. If there are no other questions, I would be ready to entertain a motion to approve the consent agenda.
Mr. Chair.
Commissioner Butts would make that motion.
All right. Commissioner Dance will second that motion.
Okay. We have a motion and a second to approve those 3 items under the consent agenda. All in favor, say aye.
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 Is there anyone opposed? All right, thank you. We'll go ahead and move to our legislative update. Mr. Lake, Director Rakow, I'm not sure who wants to lead out on this.
How about I lead out and then Bill can chime in. We've not had an executive committee for several weeks now, and so there's not a lot to report on that front where we've been watching this legislation. But this is House Bill 316, and it's the one that has to do with making changes to the state catastrophic healthcare fund as well as the county indigent funds. But there's a section in here also that has to do with public health funding, and that's the part that we're focused on. This bill originated in the House, obviously. When it got to the Senate, they made some amendments to it, and it was passed in the Senate on Monday. And then the House concurred on the amendments on Tuesday. And so it's on its way to the governor for signature and going into effect. I want to just focus on the portion that is applicable to the public health districts. Now, as county commissioners, I know that you have all been having conversations through IAC on this particular bill because it does make significant changes to your operations as well. But again, the part I want to focus on has to do with the public health district statutes. So basically what this does, it eliminates state general funding to the public health districts. Since the inception of public health districts, the state has contributed general funds. The health districts would complete a consolidated budget. So all 7 districts would submit their information and would do one budget request to the Joint Finance and Appropriations Committee. And then funding would be allocated. And most of you are very familiar with the funding formula that the trustees had established and revised over the years. And that's how that money would come to us at Public Health. This bill changes that and now puts the responsibility on the counties to fund the public health districts at the level of the fiscal year 2021 appropriations. And we're going to talk about that in much more detail when we get into the budget presentation. The implementation date is what was changed in the Senate, and this will now go into effect on March 1st. I wanted to hit some of the other highlights in this bill. Right now, the health districts are very integrated for many of the services that we receive from the state. So for an example is we work with the Division of Human Resources, and all of our hiring processes go through them. You know, and when a job is open, it's posted on the state website. We participate in PERSI and the state's health insurance program. The state's risk management program also covers us at the health districts. The state controller's office is what we use for all of our accounts payable, accounts receivable, our banking, basically. All those processes go through these state departments. And so one concern that the health districts had when talking about this bill is that we did not want to jeopardize losing any of those services. And so this item 6 right here says that we will have the option to continue with all of those service arrangements unless an agreement or service arrangement is expressly nullified by statute. That's incredibly important to us. The cost that it would take for us to go out and create our own payment system, to purchase our own insurance, it could be extremely costly, and we don't want to jeopardize those services that we receive or engage with the state. There was just another few cleanup items in the bill, striking out things that really aren't necessary. One thing that was included in here is that it is the sole responsibility of me as the director and you as the board to make the decisions regarding pay for the health district employees. We are not state employees, we're independent governmental agency. And it was from experiences that have occurred in the past, there have been some limitations that have been put on us by the state. And so it was important to the boards of health that it was clarified in here that those decisions are solely at the discretion of the local boards of health. Another modification that was made when they got to the Senate is, if you recall, Senate Bill 1060, which is the one that passed earlier in the session, requiring that if there was any public health order issued that was applicable to an entire county or more, the whole health district, that the commissioners of that county had to approve that action within 7 days. So that language was incorporated into this bill as well. And then I skipped a piece earlier. I'll just refer to it. Right now, we are the Department of Health and Welfare, as well as the Department of Environmental Quality, have delegated authority to the public health districts to perform some services on their behalf. And one example is the food protection program. Another example is the work in the septic program and landfills and a lot of things in the environmental health realm. And again, right now that is just through memorandum of agreement, delegating those responsibilities to us. In the bill, it does say that won't necessarily be by delegation now, that the health districts can enter into contractual arrangements with those agencies to continue to do that work. And then one of the other changes has to do with how the budget committee of the board is structured. It's always been that the chairman of each county commission makes up the budget committee for the health district. And previously, the chairman could give his proxy to anyone else to represent him on that at that public budget hearing. So an example, many of you are not chairman of your commissions, but your chairman has given you the proxy to be able to vote at that public budget hearing. That would still be okay for commissioners. However, like in Mr. Lake's position, he's not a currently sitting commissioner. And so he would not be able to represent Teton County at the budget committee. It has to be a county commissioner that is a currently elected county commissioner. The last section, again, just strikes out the provision for the state to provide aid to the health districts. However, it does not prevent the legislature to grant additional funds for selected projects. And it also does not impact the Millennium Fund dollars that we get. That is a separate appropriations that goes through the Millennium Fund, and we would still be eligible to receive that funding. So those are the highlights of this bill. Again, it's awaiting the governor's signature, and it will go into effect on March 1st. There is commitment by the legislators that have been involved in the bill that a lot of work still needs to be done with the hospitals, specifically on involuntary mental health holds. So work is going to continue between now and March to make sure things are in order to not adversely affect the hospitals. And I know that there's likely work to be done on the county side as well, but I will stop there and ask if there are any specific questions that I can answer.
Jerry, there was some talk earlier to put wording in that would compel the counties to provide a percentage or the same level of funding that the state had been providing. Did that get in here, or is that something they still plan to add?
No, that is in here. And again, it has to do, I'm trying to find that section, that they're required to fund us at the level of the fiscal year 21 state general fund appropriation.
Okay.
Where's the bottom?
That's good.
Where's this?
Are there other questions from board members?
Right there. You were on it.
Sorry.
Mr. Chairman, Bill Lake,
Yeah.
I just had one one comment here. Jerry, thanks for the great overview of that, because it was pretty complicated getting through everything. Ada County and Blaine County raised an issue at one of our meetings, or at one of the, actually at one of the hearings in the Senate Health and Welfare, that they didn't like the way that the county allocation was working, because the counties that have higher market valuation are paying more in what they feel was their share of what they should be paying from all the counties. And that concerned me, because I'm not really sure how market evaluation plays into the big scheme of things. But if I read the statute correctly, it allows for each district, if your counties decide they want to do a different allocation, they could actually do that. And in our case, I think Teton County valuation, probably Bonneville's, may be higher than places like, say, Clark County or Custer County. But if people hear that some of the other counties don't like this bill, there's various reasons for that. Some counties don't like it for that reason. Some counties don't like the way that the hospitals may be treated in this or something. So before anybody goes off and has concerns about the bill, there's a lot of intricacies that need to be discussed. So.
Thank you, Bill. And Mr. Chairman, if I just may, the question that you asked was right here in 39.424A, and it says, beginning on January 1st, 2022, the boards of county commissioners shall be responsible for providing additional annual aid to the health districts. The amount of such additional county aid shall not be less than the amount appropriated to the districts in fiscal year 21. And as Bill mentioned, for this particular funding, the budget committee does have the ability to change the formula of how it gets divvied out to the counties. It says in here, it should be based on the formula that's already set in statute, which is, we're going to talk about in our budget here in just a minute. It doesn't change that portion, but for this additional county aid, the budget committees can change the formula for how it's distributed.
Okay. Well, thank you. This has been a complicated piece of legislation and has gone on for 2 or 3 months. So I'm glad that they finally came to a resolution on it. In Eastern Idaho, it will cost most counties a little more money because we had been very responsible with our indigent funding. However, I think it was a reasonable compromise and something that I believe will still be very supportive to the health districts. Any other questions before we move on? Okay, let's go ahead and go then to item 5 on the agenda, the fiscal year 21 budget adjustments.
You're up.
Okay, this is Steve Thomas, and WIC has had a small grant increase for their peer counselor program and then their general WIC operations. That particular division is very close on budget, so we're requesting a small budget expansion to facilitate them getting to the end of the year. So we're talking about a total of 40,000 increase in personnel, 5,000 operating.
Okay.
And we would just need a motion to that effect. If you have any questions, I don't know if Angie's available.
She is.
Okay.
Any questions for Stephen or Angie regarding this? If not, I'm ready for a motion to approve the 21 budget adjustment.
This Commissioner Shenton, I'll make that motion.
Thank you. We have a motion. Do we have a second?
Mr.
Bill
Young,
Lake, I
second.
second.
Okay, I had Commissioner Young's second. So all in favor, say aye.
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 Is there anyone opposed? All right, thank you. We'll go ahead and move to our review and approval of the capital budget allocations. Mr. Thomas?
Okay, in the past, we have frequently done this in the fall. Last fall, we were heavily distracted with COVID meetings. And as we're moving into the end of this fiscal year, going to another, the board should, before the end of our fiscal year, relook at what we've set up as our reserved funds for the district. And our cash is up from the past. And so we're just showing in the first column what the balances were the last time the board reserved funds, some suggested changes, and then what it would be at the end. There's two sections in here. One we're looking at called capital reserve detail, which are funds that once the board designates, they sit there until the board moves those funds out of those categories. The bottom section, the operating reserve, these are restricted inside of our operating, so that, for example, this future vehicle purchases, should the director of the agency say we want to make a vehicle purchase this year, she can, on her prerogative, go into that 240,000 in that it's designated and authorized, but only on vehicles. Same thing with this emergency response, building maintenance, legal defense, and IT enhancements. A couple of those items, like IT enhancements, you'll notice used to be in the capital reserve where it couldn't actually be used without an additional action by the board. And at this point, we're requesting that be put down as a operating, designated and authorized, in that we think that the security enhancements proposed by the state, which were more or less put on hold during and just before COVID, we may well see those coming back in since the cybersecurity issues continue to be more demanding. You can see we could put a minus up there on the top for future personnel costs. And that's pretty much just like a rainy day fund. And rather than having that as a separate for personnel versus just funds for operating the district, we thought it would be more clear and simple to have that as just a one item, more or less of a rainy day fund.
We
Okay.
talk about the Chalice building.
Oh, the Chalice building, and some of you might be familiar, many may not. Over a decade ago, our board had worked together with an assisted living center in Chalice. We provided them significant upfront funding and in exchange received a 30-year prepaid lease. In not too many years in the future, we're going to have to deal with the expiration of that lease and either buying a new building or trying to find somewhere else to lease, or maybe negotiating a rent. I suspect, based on current relations with that facility, they will want a substantially higher rent than what is effectively being paid now. The 30-year prepaid rent gave us a really long-term inflation protection, but that's going to be going away. And so I felt like it might be a good time to start looking to say, let's put aside some money for when that lease expires. And that's why that's been added in as a specific line item. The rest of our buildings are pretty much owned by the district, other than in Du Bois, that's owned by the county. And we just take responsibility for maintenance. Mud Lake is also a county-owned facility where we provide some maintenance, the county provides some maintenance.
Okay. Any questions? Okay. This is another action item. I'm open to a motion to approve.
This is Commissioner Young. I'll make a motion to approve the proposed EIPH capital and operating reserve accounts designations.
This is Dr. Nelson. I second.
Thank you. We have a motion and a second. All in favor, say aye.
Aye.
Anyone opposed? Okay, thank you. We'll now move to the 2022 compensation plan.
All right, I'd just like to start with a little bit of background specifically for our new board members. We as public health districts, even though we're independent governmental agencies, as I mentioned earlier, participate through the Division of Human Resources and are required to follow the Division of Human Resources administrative rules. Because of that, we are required to submit to Division of Human Resources and the Legislative Services Office a compensation plan every year that addresses how we set salaries, what we do for salary increases. And so that is the document that I'm presenting to you today. This is a very comparable plan that we've had in place for many years. Each year we just make adjustments to what's called the change in employee compensation, or the CEC, which is would be an annual raise for employees, and we'll talk about that in just a minute. In the guidance, Division of Human Resources puts out, it tells us, some of the changes that were made to the state's pay structure. And that's what's represented in this first bullet here. So the state has a pay schedule, and I have that here. I just want to pull up and demonstrate to you if I can find it. So this is the pay structure, and then every position within our health district is designated a pay grade, and it sets a minimum and a maximum salary for that pay grade. And so when we talk about there was a pay line adjustment of 2%, that means that this minimum amount was increased 2% across the board. So that has been incorporated into, that will be effective for fiscal year 22. So we hire a new employee, say in pay grade H, the new entry salary will be $13.42, whereas if we hired someone in the last fiscal year, they would be making 2% less. And so we have had occasions, because for the past at least 4 or 5 years, adjustments 2 to 3% a year have been made to this entry wage. And last year, where no salary increases were implemented, a new employee coming in basically right now could be making more than someone that started with us 6 months ago for that reason alone. Okay. Our health district has historically been very conservative in our budgeting, not just for salaries, but our overall budgeting. And it has been the policy of our agency basically to start employees at the minimum pay rate. However, you'll see here a little bit later in this plan that we give credit for different, for education or different certifications and experience that would bring someone in at a higher salary than the minimum. However, other health districts have incorporated policies that say we're going to start our employees at 75% of the minimum or 80% of policy is what these are saying. But our district has historically brought people in at the minimum pay range, which as a result has put us at near the bottom of salaries for all of the 7 health districts. I was not able this year to get from the Division of Human Resources, and it's not made publicly available anymore. It used to be included in the annual CEC report, the average compa ratio for all of the state agencies and the health districts, but that's no longer included. So I don't have anything to be able to analyze where we sit in position to the other, in relation to the other health districts. So as you go through this policy, it just talks about how salary decisions are made when a new employee comes into the health district. Again, typically someone's hired at the entry level of the job classification. We have a couple of other options that if we're bringing in a hard to fill position, that the division directors have the ability to bring a person in up to 85% of policy. And then we do have situation that case by case scenarios, and sometimes this really has to do with like our clinical providers, our nurse practitioners, that the entry rate for them based on the state's pay scale is far below market value, and we have to make significant adjustments to be able to actually be successful in hiring those type of positions. And then much of this is just based out of the Division of Human Resources administrative rules. We have to follow everything that are in those rules. Typically, employees don't get paid out cash overtime. If they work over their 40 hours in a week, it is considered compensatory time, and it's banked, and then they can take that time off at a later date. We talk about in here performance evaluations. We do use the state's performance management tool. It's called iPerform. And it just talks about our process for doing evaluations. I'm going to skip down here now to the appendix. And this is what I mentioned earlier. When a new employee comes to us, we do give them credit for any education that they've attained above the minimum requirement for the job. And so if someone were to come to us that had a doctorate degree in a relevant field, they could get up to 8% more in their starting salary. We do allow up to 10% more for related experience. We have incorporated into our policy that if someone is bilingual in Spanish, that is a very valuable skill to us. And so we give them a little bit more salary for that. And then any related professional licenses. One example would be So this would mean that it's not required for the job. So like if we're hiring an RN, they are required to have their certificate and they don't necessarily get that extra credit because it's required for them to do that job. But on the other hand, if, for example, an environmental health specialist come in that has specific certification, it's not required for that position. And so they could get a little bit more. So in the level 1 category, individual starting could get up to 15% over the entry salary as they come in as a new employee. Are there any questions about that before I jump into the information on the salary increases for the coming year?
Any questions? Jerry?
Mr. Chair, Bill Lake.
Go ahead, Bill.
So Jerry, you mentioned, we talked about overtime and I guess I want to bring up loss of vacation over the last year. So did I understand this correctly that during the last year that no one on your staff got paid overtime for any extra hours they put in?
Bill, thank you for that question. And this last year has been an anomaly, obviously. And so we did work with the Board of Examiners and got an exemption for employees so that if they did work over their 40 hours in a week, they would get paid out overtime. For professional staff, that is, straight time. And then for others, it could be time and a half. That exception did not apply to executive employees, which includes me, James, Amy, the division administrators, who get paid just a set salary regardless of the number of hours that are worked. But staff who worked overtime did get paid out for it during this year. And that will be, that is extended through the end of this calendar year because of the COVID emergency.
Mr. Chairman, question
Okay.
for Jerry.
Go ahead.
Commissioner Butts. Jerry, we do not allow comp time. We just pay it out, correct?
Are you talking we, the health district?
Yes.
No, we do allow comp time. In fact, that is the default.
Okay. And how many hours do we allow them to accrue in 1 year?
Our policy does address that. We don't want people to accrue more than 40 hours without specific approval and a real good reason for accruing that much comp time. We do our very best to try to keep people within their budgeted hours. But there are times when on a normal year, for example, maybe flu season is a good example where the nurses are having to work extra during a short period and it creates a lot of extra billing for the division. And so some of our billers have to work extra and our clerical staff to do the medical encounters. And so there are situations within a year that we do have to allow people to have comp time. But generally we try to keep people within their budgeted hours. And I'm trying to get to where it is in here, right here. But we don't want them to have over 40 hours of comp time.
Okay, thank you.
You're welcome.
Mr. Commissioner, this is Commissioner Dance.
Go ahead.
Just a comment. You do run into a problem with comp time without this limitation in the event of retirees or others who are leaving when they need to be paid out their comp time, which can affect the budget adversely.
Commissioner Dance, I would just say within the structure of the state system, employees do not get paid out for comp time. They would have to be used before retirement. It's not paid out like vacation time would be.
Jerry, a couple of questions. I had one, would it take a board action to allow overtime for your executive team? And should have that been done, or is there a state requirement that does not allow that for you and your others?
Yeah, it is more the state level. I'm going to give an example that early on in the pandemic, when many hours were being worked by me and several of the staff, there was a discussion with the Division of Human Resources to potentially allow, remove the cap on accrued vacation because myself and some other staff are at the maximum accrual for vacation. And that was not approved. It would have to be an action by the State Board of Examiners, and that request was not considered by them. And so for the last year, some employees have been losing vacation time every single pay period, and there's nothing that we've been able to do about that.
I can't imagine how many hours you've lost this past year due to that. And I think that, you know, I'm somewhat upset that that was allowed to happen during a time when you would think that we would need to give the most support to public health officers. The state did not allow that. The other question is it time for our health district to increase that to 75% for starting wages so that we don't continue to fall behind? Are you going to recommend that in your proposal?
That is something, Mr. Chairman, that we've talked about over the years. The challenge is the funding that it would take to do that. And it's not just the starting salaries, because it would, to me, not be equitable to start new employees at that higher level when employees that have been here for a long time. It would create a lot of internal equity compression. And so we've not been able to find a way to financially afford to be able to make significant adjustments to that. But it's something probably we should look at again and see if there are some things that we could do. So thank you for asking that question. It's not incorporated into today's compensation plan, but is something that we can continue to look at and bring back to the board at a later date.
Well, I hope you will. We do need to find out a way to continue to do that, because it was obvious this year that, you know, our health district was leading the charge amongst the state, amongst all the health districts. And it's unfortunate that, you know, we have gotten ourselves into this hole where we are one of the lower paid districts. That's a correction I think I would like to ask you to explore in a way we can fix that.
So that's a good lead into this section on this year's proposed CEC matrix. And you will see here that we have incorporated higher percentages of raises this year than you've ever seen before. Last year, no raises were allowed to be given. For some of you that were on the board, you may recall that we did budget for raises. We did have a plan in place, and our plan was to, in January, if our budget allowed, to implement a raise for all of our employees. Unfortunately, that was not permitted by the Division of Human Resources. So the state, I mentioned to you earlier that we get recommendations or the guidance from the state, and the legislature for state agencies approved a total of 4% CEC for employees. 2 was to make up for last year that no raises occurred, and then another 2% for fiscal year 22. But you can see here, I'm proposing an average of a 6% salary increase for employees. And it's not an across the board raise. It is based on employees' performance, as well as where they are in the comp ratio. And if you recall, I'm going to go back to the pay schedule that I showed you earlier to explain the comp ratio. Okay, so you can see here this what's called policy, and that is what has been explained about what the market rate should be. As a state, they've done evaluations of the compensation and benefits packages of state of Idaho employees, as well as health districts, because we participate in the benefits package, and have found consistently that the salaries are under market for comparable positions in surrounding states. But when you're talking about policy and the comp ratio is where people are in position in relation to this policy number. And so if people were at 100%, they would be making this, this amount that you see in this middle column. Now let me go back to the other page. I don't have the number readily off my head, but I can tell you the people that are making 100% of policy in our agency, I can count on one hand. And I would say the majority are, you know, in 70 to 89% policy. And so you can see here that it's a higher percentage of increase for these employees to get them higher in that pay grade. And actually that is a requirement in Idaho code that people that are at the bottom of the pay grade advance more quickly through the pay structure than those that are a higher policy level. And so that is a requirement of the matrix, that those in the lower comp ratio get a higher percentage increase than those that are near the top. So you'll see a 0.5% difference between the evaluation ratings for this lower comp ratio area, and then between each comp ratio, it's a 1/4 of a point percentage increase. So as we go through, every employee has to have an annual evaluation, and based on their evaluation and then where they are in this comp ratio, that determines where they would fit in this matrix, and that would determine the amount of salary increase that they would get. A couple of other things is we are applying this to all employees. We have a significant number of temporary employees this year. On average, we have about 110 employees. At the height of the COVID response, we were at 160 employees with a lot of temporaries. We've hired on a lot for the disease investigation, the contact tracers, nurses, clerical staff. Those numbers have come down significantly as our case counts have reduced. We have, done away with some of the temporary contact tracers. Right now, we still have a lot of temporary staff and clinical services that are assisting with the vaccination effort. But the raise would apply to everyone once they have been here for 6 months. Another thing that I'm proposing is that the fiscal year, to be effective for fiscal year 22, it would become effective, I want to say, June 13th, but I would like to implement the raises 1 month early, effective May 14th. And that would be paid out to employees on their June 11th paycheck.
Well, does that include your executive team?
Yes, it does.
Okay. The one issue that we may have with that, and it has been caused because of, the need to meet remotely and it's made these meetings a little more difficult, is we have not been able to do your evaluation yet for our director board. And that is a responsibility of our board. It wasn't able to be done all of last year, so we are behind on that. So I would like to propose that in the motion today to approve this, that we also make part of that motion that we will conduct that evaluation on our next meeting on June 3rd. And that whatever action we take at that time, we will grandfather, I don't know what the word is, but we will backdate that so that our director is not penalized by our lack of being able to do that evaluation. Is there any discussion from the board on that, or any concerns, any questions?
Chairman Reed and Jerry?
Yeah, go ahead, Commissioner Madsen.
I'm going to have to cut out. I have an emergency call I have to take. So I just don't want you to not just see me just exit my screen.
Thank you. We will get back to you with the information. Good luck on your call.
Thank you.
Mr. Chair, Bill Lake.
Go ahead, Bill.
A question. So, Jerry, with this House Bill 316, does this have to be approved also by the state now after we approve it?
Well, I think the answer is yes, simply because that bill doesn't go into effect until March of 22.
Okay. So we do have some risks there, but after that, in the future, we won't have to go to the state for approval. Is that correct?
That is my understanding.
Okay, thank you.
And when that takes effect in March, will that then be for the next year's compensation package? Is that correct?
I believe so. I think there's still a lot of unknowns of how this is going to play out. And so I don't have a definitive answer on that. There's a lot of work I think that we as the health district directors need to do in communicating with the Division of Human Resources and the other programs that we work with now to really understand, how it will look going forward. And hopefully I'll be able to share more with you in the coming board meetings, but I just don't have all those answers right now.
Okay. Other questions by board members?
Mr. Chair, this is Commissioner Dance. I just was curious on your making that compensation to, say, Jerry, retroactive, what it would be retroactive to what time period or what date?
I would propose that we make it under the same terms that she is proposing for the rest of the staff. So it'd be retroactive to the May 14th. And again, it'll all be determined by the evaluation that we perform at that June 3rd meeting.
And Mr. Chairman, I will just tell you that it's very likely DHR will not allow a retro pay change. So it would just go into effect the day that you take the action. Steve's wanting to talk.
Could I jump in as a suggestion? The board could, without evaluation, as the governor's direction is that agencies with independent boards do a letter suggesting the pay increase for the director. Is that either you guys do an executive session at the end of this meeting or at a very soon point of time, early enough before this May date that we can present that letter from the board to the governor's office, because as long as we are under the current DHR rules, that's going to be a challenge for us with the director's salary. And if that doesn't work, I would suggest that as soon after March 1, as the board would see fit, that you hold a meeting, and at that point, when you actually have total authority, you direct what the director's salary might be.
Okay,
Mr. Chairman, Commissioner Butts.
go ahead, Commissioner.
I don't think we could make that motion today because we don't have it posted as an action item.
No, we won't be able to certainly do the executive session. Well, with that heard, let's just make the motion if the board sees fit on what's being presented today. And then we will go ahead and take our board action at our June 3rd meeting in regards to our director. Other questions? Okay, I appreciate the work you've done on this, Jerry, and it is very justified. I have followed every health district very closely through the entire winter, and I can assure the board members, and I'm sure it's been evident in your own observation, that our health district has been leading the way in their response. They have been on top of everything that has been asked of them. They have led the way in the way of information, in transparency, through the reporting, and now through the vaccines. So we have a very good staff at our health district that's led by a very competent director. And so I believe that this compensation package is very justified, and I hope it'll begin to make up some ground that we lost over the last several years. Any other questions from the board? If not, I'm ready for a motion.
Mr. Chairman.
Chair Bill Lake, I make a motion that we approve the compensation package as presented.
I was slow.
Okay, we've got a motion. Do we have a second?
Commissioner Dance, I'll second that.
Okay. Motion and a second. Are there any discussion on the motion?
Okay, but is that these rapid chargers that
all in favor, say aye.
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 Is there anyone opposed? All right, thank you.
All right, thank you.
We'll now move on to the next item, our budget proposal for 2022.
Okay, I just want to say that it was a little bit challenging to develop this budget based on the uncertainties of House Bill 316. We did put this together with the assumption that 316 would pass, and so we've incorporated the additional funding that will be required by the counties. But some of our numbers are not set in stone yet. So we'll walk through this, and I'm going to do my very best to explain the county piece. But here we go. Please jump in at any time if you have questions, okay? Just in the introductory summary, obviously our budget is higher for fiscal year 22 than it was for 21. And a good part of that is based on the continuing COVID response and additional funding that we've received for those activities. And we'll talk more about those as we get into some of the revenue discussions. I just explained that the effect of House Bill 316 on the state general fund. So at this point in time, we have our appropriation bill that's sitting out there waiting for approval. It's on the third reading calendar of the House. However, with the passage of 316, I suspect that they will be amending that bill to reduce the state's contribution, so it's not for a full year. Now, one thing that just came to light as we were going through House Bill 316 is I based it on the March 1st date for the counties to start contributing. But in the bill, it very clearly states starting January 1, the counties have to pay that additional funding. So what I'm not clear on is if it's going to be January 1 or March 1. This budget that we put in for the extra county funding was based on a March 1 date. So please just understand that that might change as we get the full clarity on that bill, which I hope to be very soon because I start meeting with all of your counties starting next week to present the budget. This year, we are not asking for any increase in the normal county appropriations. And for the past 2 years, we have not asked for increases from the counties. And that is continuing this year. Our fees, we're budgeting a 17% increase in fee revenue because of increased activity in many of the environmental health programs, the septic program, land development, and food protection, and in immunizations. COVID immunizations play a little piece in that, but just our overall everyday immunization program has historically been very, very busy, and it is actually the leading immunization program in the state. And so we are anticipating some increases in that program again this year. In our subgrants, again, most of our subgrants come through the Department of the Department of Health and Welfare. But we do have a couple, one through the Office of Drug Policy, and then also the Department of Environmental Quality. But overall, we're anticipating a 30% increase in subgrant funding. And 70% of that increase is due to money that has been allocated to us to continue with the disease investigation and contact tracing and epidemiological work. Also in this budget is a $30,000 subgrant that was not included in last year's budget, but it was initiated during the last year. It started after our budget was presented, and so it was not included. It's a level funding that we received for this current fiscal year is going into next year, but that amount will now be included in our budget. And then we have increased funding for WIC, and we talked about some of that this morning with the budget adjustment, and a little more funding in our tobacco and education prevention program. And then other subgrants, we see minor fluctuations, either up or down just a little bit. But as I mentioned earlier about the oral health subgrant, we have made the decision internally to not accept that subgrant anymore. And there's a couple of reasons for that. One significant is that the staff that had been here left for another job. And it's been a program that we've historically had to put district dollars into to support that work. It involves doing dental varnish and dental sealants and fluoride with the schools. And for kids, we reached out to, James did reach out to several dentists in the area to seek feedback. And our area does not have any shortage of dental providers, and children should have access through Medicaid to a dental provider. And so the work that we're doing sometimes overlapped with the work that would be done in a normal dental home. And so we have made the decision not to continue with that program. Another one that we have chosen not to renew going into the next fiscal year is the Hospital Preparedness Program. And that is one that has been in place since 2002 when the Public Health Preparedness Program initiated. The funding that we receive for that help staff a part-time employee that was really the liaison for a lot of the healthcare coalition. And you should all at least be familiar with that many of your emergency managers participate in that coalition. The focus of that coalition the structure of it, I guess, has changed over the past few years, and it's becoming more regional. And so regions, districts 7, 6, and 5 have now combined into one large coalition, but it's being more driven by the hospital leadership. And so our staff person in that program retired a few months ago, and we have chosen not to continue with that subgrant. Our staff, our preparedness staff, will still be engaged and participate in that coalition. We're just not going to be the facilitator of that going forward. Are there any questions on the revenue side of things? Okay, sorry. Moving into the expenses, we've already talked about the salaries. We did include funding in the budget for the average 6% salary increase. Employee benefits, I know you probably experienced this as well, but for many years in the past, we saw the employer cost of health insurance increase significantly, double digit. We are not seeing any change in the cost of the employer benefit cost. So we as a health district don't have to pay more for employee benefits. However, for fiscal year 22, the employees will all be paying more for those benefits as their premiums are increasing, on an average of 8.7% for the medical insurance for full-time employees, and part-time employees, it's an average increase of 3.15%. Our operating expenses have increased a little bit. Obviously, as we're doing more vaccination work, there's more supplies that are required, as well as just the cost of supplies, as you all, I'm sure, are well aware, have increased significantly because of the impact of COVID. And so those are the highlights. If there's no questions, I'll just get into the numbers now. So this first chart represents the revenue, both in subgrants and fees for each of the divisions. Obviously, the Board of Health doesn't generate fees or subgrants, but each of the other divisions do. So for clinical services, you can see what we're anticipating bringing in both in subgrants and fees, and you see that for each of the divisions. The total is $1.15 million more than last year, a 30% increase over last year for subgrants, and then a 17% increase in fees. On the expense side of things, we're budgeting $9,497,157. You can see down below the change. Obviously, you can incorporate it in the salaries is the cost of the CEC that we just talked about. So that will make that go up from last year, as well as when salaries increase, the cost of benefit increases a little bit also because it's based on the salary, and then operating expenses, the increase there. Are there any questions about that?
Mr. Chair, I have one question.
Go ahead.
So Jerry, make sure I understand, if the medical expenses for the employees are going up 8.7% and 4.2% for dental, yet we're only going to give a raise of, say, an average 6%, that means overall an employee is going to take a reduction in pay next year.
No, and I don't know if Steve wants to.
I was going to jump in on that, Bill. That the employee medical cost is a small fraction of their total wage. So when you calculate a percent increase on what they're paying out for medical, it's not a direct correlation with a percent of their wage.
Okay,
So
I understand
for
now.
example, an employee could pay $50 a pay period for their medical insurance. And now maybe it's going up to $53. So when you add the dollar amount, it's not as much as what they're going to be seeing in their salary increase on an hourly rate.
Okay, thank you.
But that's a good question. Thank you for noticing that. Okay, this is where we show you the summary of all the funding sources. And so when we go down here looking at the subgrants, we've already talked about those. Fees, we talked about those. County contributions, again, remain the same for what they have been over last year. And then this is where we're going to see some changes in the state, the state appropriation. And this is where we don't have a definitive number. This was the amount we got last year. We have not seen exactly what that bill is going to be. And then that has to run through the trustee formula. And so this was our best guess of what that would be. But again, it's only based on, it's based on 2/3 of the year, anticipating that was going to go into effect in March. So likely this number is going to change. Interest, we did bump up a little bit by $10,000. And then we're budgeting in all the COVID work that we're doing and the funding that we're getting to do that work. We would like to budget $400,000 carry over into next year that will assist us in doing that work. Once a shot is given, that's not the end, right? That's one piece of it. And then there's a lot of work on the back end to input that into the medical record, to input it into IRIS. And so there's a lot of work that has to be done on the backside. And so we want to carry over $400,000 in funding that we're getting this fiscal year to help us with that work that will continue into the next fiscal year. And then this 379 is what we had anticipated the counties would be, the extra funding the counties would be responsible for based on the House Bill 316. And we'll talk about that more here in just a minute. So our total revenue is $9.7 million. And so you can see right here that we think we're going to have a carryover already just based on what our current operating budget is. And I want to come back and talk about that here a little bit later. This is just a comparison between last year and this year. Again, most significantly showing the change in appropriations and some increase in subgrants with the extra, and then obviously the extra carryover where we're budgeting for $400,000. Okay, I want to get into the county piece now, and this should look very familiar to all of you except for Commissioner Dance, and we kind of talked about this with him when we did orientation, but in Idaho Code 39425, it sets out the formula by which the counties contribute to the health district. And so it is based on 70% of the county's population and 30% on the taxable market value. And so we have, we were not able to get census numbers from the U.S. Census Bureau this year. They did not publish them. And so the Idaho Department of Commerce did provide us with projections, estimates. And so that's what is incorporated in here. Your county taxable market value that is received by the State Tax Commission. So when you scroll down here, even though we have no change, no increase in the county contribution total amount, it does fluctuate from year to year based on your population and your taxable market value. So going into fiscal year 22, you can see all counties except for Bonneville and Jefferson are experiencing a reduction over what they paid last year. But Bonneville and Jefferson, because of increases in either population and taxable market value, they will see an increase in their appropriation. We do have the supporting information back here in the back of the budget, so you can see the change for your individual county in both the population and the property values.
Jerry, I have
yes.
a question on that. So you've got the right there. Go down a little bit. The other way down.
Okay.
Go up. Keep going. Next page.
Keep down here. Sorry.
Right there. Oops. So you had our, can you go up to the next page? Right there.
So this is one we haven't talked about yet. That's the 316.
Okay, I'm just
back to this one.
I'm just curious about the 2020 taxable market value.
Okay.
Where you're pulling that number from, because further down, I think you show that as the 2022 taxable market value.
That is likely just a error.
Okay, so this column right there should show 2022. Is that are you pulling that as a future number?
No.
Mr. Chairman, this is Steve Thomas. When it's showing FY 2022, that's the column saying we're calculating the FY 22 county appropriations, but the data is coming from 2020 taxable market value. So you can see at the top of this column, it's saying it's the 2020 taxable market value, but it's for the 2022 contribution.
Budget, yeah.
And that may be confusing. I mean, we could potentially change that because the FY21 is for the FY21.
What was calculated for our budget.
Yeah, that's for the 21 contribution, but it's actually the 19 population, and the FY22 contribution is based on the FY 2020 population. So
we could definitely change those labels to make it less confusing.
Is what really confused me, and I don't mean to belabor it, but go down just a little further to the county property values. That's showing an increase over 2021 for the county valuation.
Correct, and this one has the same date offsets in that the FY 2021 is for that contribution year, but that's actually FY 19 county valuations, and FY 2022 is for the contribution year of FY 2022, but it's FY 2020 county valuation.
Okay, I'm with you now. It's always lagging a year.
And we can certainly
Almost 2 years.
change that to make that more clear.
If it would make better sense to you guys, and we've been using the schedule with this dating process for a long time. And I think most people haven't looked at it close, but you're right. It does seem confusing.
Okay, I understand.
Thank you for asking that.
Mr. Chair, comment on that?
Yes, please.
Maybe instead of, since we've been doing it this way for so long, maybe just a footnote to clarify that so that we don't, as we're looking back at past budgets, for whatever reason, it doesn't get more confusing.
Yeah, we can certainly do that. That's good.
Good idea.
Okay.
Okay, now I want to talk about what we thought we were projecting for the county contributions resulting from House Bill 316. And we already talked about all this information. One thing I want to point out here is that for fiscal year 21, our original appropriation was almost $1.2 million. And then we also had $19,500 that was designated for the citizen review panel. So our total amount of state general funds was this 1.2. But during the year, there was a 5% holdback on the state general funds. And so we've deducted that from the total amount, giving us the $1,150,400 that we're basing this new formula on. So we still use, and again, this is up for discussion with the board, right? Because we just plugged it in based on the same formula in 39,424, based on 70% population, 30% property values, and plugged it through that same formula. And so these numbers represent, in the red, the additional funding that the counties will be responsible for contributing to the health district to make up for the state general funds that will be removed.
And you're basing that on a March date, and
Yes.
that would be higher if it was a January.
Yes. It would be higher. And I
think the key will be seeing what they put on our final appropriations bill, because the way they date the appropriations bill and how they adjust that will give us clear direction on the date that the counties start.
So I'm going to propose today that we don't take an action on this particular piece, that we just take action on the normal county contributions as well as our operating budget. And then we can come back later when we have all the information, know what this is going to be, and talk about that in more detail. And again, I really hope I have that information by the time I come to your county's commissions to present the budget to them. But what would be needed today is action to approve this portion of the county appropriations, the historical, and then our operating budget. And I just want to point out, as the chairman said earlier, we know that for most of our counties, it is going to be increased costs for you over what savings you would have, or you're going to realize from the county indigent fund reduction. Lemhi County, to my knowledge, is the only one that is not in that position. And again, as outlined in the bill, the budget committee can choose a different formula for distributing this, this dollar amount among the counties in the health district. And so that could be a discussion during our budget hearing. I guess I would just like to turn to you and just see your initial thoughts and what direction you would give me going forward.
Any input from the board? Jerry, I think it's a very reasonable budget. I know you've worked hard on this. It seems very prudent, and particularly coming off the year we have and the continued challenges going forward. It all looks good to me. Is there comments from other board members?
Well, this is Commissioner Young. I would say, yeah, what they've done is very well. I don't know what you can do with when you have to guess what the legislature will do, and you can only do your best educated guess on it, and that's about, it looks appropriate to me.
Mr. Chairman, if I may, I'd like to go back up here where I had mentioned we have potential carryover. We've not designated that for anything in particular, but I would throw out the option that we could, for this first year, use that to credit towards this amount for just a one-time reduction in what the counties would have to pay as we transition into this new process. Again, if we do that, I want to make it very clear that it would only be a one-time option. And then obviously next year, the counties would be, responsible for that full, this amount. Sorry, this amount.
Mr. Chairman.
Not even on there.
Mr. Chairman, this is Commissioner Butts. Question for Jerry.
Go ahead, Commissioner.
Wouldn't it be better to hold that money over if we can for a rainy day in case we get in trouble?
We certainly could do that as well.
Yeah, I was thinking that same thing, Commissioner Butts, but I think we leave it as you've indicated it now as a potential carryover. And then when we know more for end of the year, we can take action on that if we want to use it toward a credit.
Mr. Chairman, if there's no other further conversation, I would make it a motion to accept the proposal.
Thank you for that motion. Is there a second?
Commissioner Shenton, I'll second it.
Okay, we have a motion and a second to approve the 2022 budget proposal as presented. Is there discussion on that motion?
Mr. Chairman, I'm sorry, if I may first, could I ask that we have two separate motions, one for the operating budget and then one for the normal county appropriations?
Okay.
Commissioner Dance here, we may also need to state that we are not including the HB 316 potential appropriation in this proposal or in this motion.
That goes towards the two separate motions for the specific pieces. So one motion for the approval of the operating budget, and then one motion for the approval of the normal county appropriations. And then we'll come back and revisit the House Bill 316 appropriation at a later date.
So Commissioner Butts, would you be willing to withdraw your motion and clarify it on just one of these items?
Yes, I would. And my motion would represent the first proposal, the number one.
We have a motion to approve the operating budget.
That's correct.
Is there a second?
I'll second it, Commissioner Shenton.
Okay, so we have a motion and a second to approve the 2022 operating budget. Is there any discussion on that motion? Hearing none, all in favor say aye.
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 Is there anyone opposed? Did anyone abstain? All right, thank you. So now we are looking at the piece that deals with the county appropriations. Would anybody willing to make a motion to approve this portion?
This is Commissioner Dance. I'd make a motion that we approve the regular county appropriations as stated by Director Gracow.
Thank you. Is there a second?
Commissioner Young seconds.
Okay. We have a motion and a second to request the county appropriations that have been presented for the coming fiscal year. Is there any discussions or questions on that motion? Hearing none, all in favor say aye.
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 Is there anyone opposed? Did anybody abstain? Okay, thank you.
Yes, thank you all very much. I know it's a little confusing and we still have a lot of uncertainty, but again, I hope that we'll have some clarity by the time I meet with your commission. So thank you for that.
Well, take that unanimous vote as a support for all the work that you and your staff are doing.
Thank you. The last thing, Mr. Chairman, if you'd like me to move on, is the proposed meeting schedule for the rest of this year.
Yes.
Okay, our next regularly scheduled meeting is on June 3rd. And I would like to propose that we just incorporate the public hearing, the budget hearing, into that meeting with a start time at 9 a.m. I would propose that the budget hearing be held first, and that's where we would invite the chairs of the commissions to participate if they so choose. Typically, the budget hearing only takes a few minutes. It might take a little bit longer this year with the House Bill 316 that they want to talk about, and especially if there's going to be dialogue about changing how the formula is used for that portion of the funding. But I can touch base as we get a little bit closer, but I propose 9 a.m. to start with the public budget hearing and then have the rest of our meeting after that.
Jerry, can I ask if we can do that meeting in person? Will you have a room available?
Yes, we do. And it would probably be helpful to have that in person.
Okay. And part of that meeting we will make sure to put on your agenda your evaluation as well.
Okay.
And a executive session.
Okay. June 17th, we had you hold that date before for the final decision has been made that instead of having the full IAB conference, they are just going to do the business meeting. It will start at 1:30 and go as long as it takes to get the business completed. There is an option to go in person if you so choose, but from what I understand from most of the districts, it will be virtual participation in that business meeting. If you recall, last year, I think the whole thing was completed within 30 minutes or so. But more information will be coming, but please put it down for 1:30 p.m. on June 17th. And if you desire to go there in person, please let me know that so I can work with you on those arrangements. And then I'm proposing that we resume our normal meeting schedule. Historically, we have not met in June or July or August. And then we go back to what would be, the almost full day meetings, typically 9 to 3 here in person at the health department. We have over the last week, I would say, been able to move staff out of the conference room and into other office space. So that is now available for us that we can resume meeting in person. We'll always have a virtual option as well. So for those that aren't able to be in person, but I would propose starting with our June 3rd meeting, we resume meeting in person.
Sounds good.
And I guess one question that I had as I'm putting this together, historically, we've done the legislative reception in conjunction with our November meeting. Is that something that we still want to do? And we have time to decide that, but with the change in, no longer getting state funding and less involvement on the state side of things, I don't think it's a bad thing to continue to educate legislators on public health. So I just put that on there, for consideration. And again, we don't have to make any decision on that today.
Okay. Is there any questions or are those meeting dates of any concern for board members? It will be nice to get back to in-person meetings and being able to conduct a broader need of business for Eastern Idaho Public Health.
We agree.
Okay. You have this as an action item, Jerry. Do you want a motion to approve this meeting schedule?
I don't know that it requires a formal motion. If there's just consensus, that's fine too.
I think that's all that's necessary. Is there, I'm hearing no concerns. Okay, I think we've completed our agenda. Is there any item, Jerry, that you need to circle back to, or any closing remarks?
No, no other agenda items. I just do want to say, express my sincere gratitude and appreciation to each and every one of you and the continued support that you have provided us at Eastern Idaho Public Health over this last year. As you mentioned earlier, that you felt like our district has led the way. I would echo that sentiment for our board. I think our board has been a leader throughout this pandemic, and I just can't tell you how grateful I am for all of that. So just want you to know that.
Thank you. I appreciate that, and we do, and yeah, we're fortunate to live in Eastern Idaho in a good area with a lot of good people, and we've weathered through quite a storm this year, and just continue to feel for those who, you know, will continue to be sick, but encourage everyone to be vaccinated. Is certainly the path forward. It has been so nice for me to be able to attend events and do family functions and everything with my 90-year-old father. I've mentioned him in this meeting before because it's been kind of a personal way that I know how everybody feels. Everybody has those same family and acquaintances in their lives. And we're doing that with just full confidence and just living life as it should be, because he's vaccinated and because we all are. So we would just encourage everybody to do that. We're now into this, and there's been so much given that we know the safety is there, and we know the efficacy is there. And so I'm glad that we're at that point. Are there any final comments from any board members before I close the meeting? Okay, thank you everyone for all of your work, and particularly all of you at Eastern Idaho Public Health. So we will see you all in June then, June 3rd in person.
Thank you all.
Thank you.